I think the biggest misconception that kind of irks me all the time, you hear testosterone and the first image that goes through most people's heads is Arnold Schwarzenegger or Phil Heath and just building muscle, right? That's what everybody thinks of.
Right.
But it's so much more than that. It is the fundamental chemical messenger in your body that's got all these pathways it works on. And when it goes down, you're not just losing muscle mass. Like, it affects your neurotransmitters, your dopamine, your norepinephrine, all these things that make you feel happy and good about yourself. It's good for guys to know that it's not just testosterone. Testosterone is just not linked to muscle mass, right? There's got all these other effects that helps you live a better life. Thanks for joining us for our first episode of The Honest Dose. Glad to have you here. So just going back into our backgrounds, right? Like, we met shortly after you got out of pharmacy school. What made you go into pharmacy to start off with? And then how did that evolve into going into medicine?
So pharmacy came to fruition. I was about to be a junior and I had no idea what I wanted to do. And my mom said, you know, maybe you should be a pharmacist. She planted that seed. And I actually worked in the former dean of the pharmacy school's lab. We were studying...
That was Stephen Leslie, right?
Stephen Leslie, yes.
Stephen Leslie.
Studying fetal alcohol syndrome. Funny interview. When I interviewed for that position, the lab leader brought me in and said, "You here for the position?" "Yeah." "Okay, what I want you to do is anesthetize this mouse, remove its brain, and then we're going to dissect the brain." That was my interview.
Oh my God. I mean, Did you even know how to get to the brain of a mouse? Like, it's not like we take anatomy classes in undergrad.
Well, no, I mean, I learned like literally on the job. She was like, "This is how you do it." That was my interview. She's like, "Well, I had to make sure you had the stomach to actually do this."
Got it.
So I worked in his lab for 2 years. And one day he said, "Well, I think you'd be a good pharmacist. Why don't you come to pharmacy school?" And came to UT. And pharmacy school was amazing here. It really set the foundation for who I am, how I think about the world. I still tell people I'm a pharmacist first, physician second, entrepreneur third, because everything colors through that lens of the leadership, the way we evaluate data, our process-driven, our patient-centric care. Everything centers from being a pharmacist first. And I'm really glad that we're doing this, because one of the things that drives me bananas online is that people talk about drugs and supplements. And the first question I ask them is, "What is your background in pharmacology?"
Yeah.
And it's crickets.
Yep.
Right. So I love amplifying pharmacists to talk about these things because we are the subject matter experts in this. And no one gets education in pharmacology, pharmacokinetics like us.
Another thing we have in common besides pharmacy is the fact that we're new dads, right? So how's your little boy doing?
So I thought before I became a dad that my heart was full and that I had an amazing life, because I've done some really cool stuff. I get to save people for a living, right? I never knew that I was capable of love to the degree that I'm capable now. I never knew my heart could be as full as it is now.
It's the best thing that's ever happened to me too, right? I think we get, especially first-time dads after marriage and all that, you don't know what you don't know yet. And when they just show up, it's like, oh my God, like, I have to take care of you and I have to show you the path now, but it is so rewarding. It's a rewarding experience, but it also does affect your lifestyle, your body, your hormones. So, there's data out there showing, and we see this even in our practices, right? Where new dads have declining hormone levels. The testosterone declines 10 to 15% or so right after when they're in that mating period, if you want to call it. What else are you seeing when you see these new dads?
Their stress levels are through the roof, right?
So their cortisol's off.
Right. And not just that, we know what comes with stress, right? Increased inflammatory markers, blood pressure increases, testosterone lowers. You get both physiological changes as far as hormone goes, but you get subjective, like, I feel this, right? Headaches or rashes or brain fog, all of these manifestations. And then you also see somewhat like this, your focus is so much shifted on something else that you start to neglect yourself and your own health.
Yeah.
And you start to put yourself secondary. But I've always been a firm believer, and I don't want to put words in your mouth, I think you are too, that you have to take care of yourself first. If I'm going to be the father that I want to be, the husband I want to be, the business owner, the physician I want to be, I've got to prioritize my own assets, right?
Yeah.
And so it's really rewarding to work with these dads in a comprehensive manner to help them get back to the vitality that they used to have, that now they want to carry forward to be able to do what they want to accomplish in life.
Yeah. And that's a good point. So new dads typically, I mean, now people are becoming dads later in life, and we've seen the studies on that. People in general are waiting to get married later. They're having kids later, prioritizing their careers a little bit more, both men and women. So what should a guy be doing, like preventatively, right? Preemptively, to combat this decline in testosterone that's coming? Can they prioritize their sleep? How can they manage their stress a bit more when they're going through this mating period, if you want to call it, or I'm about to be a dad period?
Preparation is everything, right? And it's not saying that you can control your kid's going to do whatever. We know that, right? You just don't know how things are going to go. But I'm a firm believer of control what you can control. Every single variable that's under my control, I'm going to try to optimize. And that starts before you have a kid, right? So what is your nutrition looking like? What is your nutritional strategy? Are you just winging every single meal? Or do you have a plan in line for what your goals are? What's your exercise routine look like? It doesn't have to be an hour in the gym. We know from the data on exercise snacks recently that you can get good fitness by small exercise routines throughout the day. Even like a minute, 10 or 20 times a day can get you good fitness results.
Yeah.
Looking at your mindset, your perception, how do you view the world? We know that a lot of people carry forward childhood trauma and they never address it. Right. And then you end up with generational curses, the activities that your parents used to do, you just do without thinking about it, but you know how that affected you.
Yeah.
Right. So I thought about this stuff for a long time and tried to optimize everything I could optimize before becoming a father, because I wanted to be a patient father. I wanted to be a loving father. I wanted to be a kind father, but I wanted to be a disciplined father.
Yeah.
Because I believe that kids aren't going to listen to you, but they will do what you do.
Exactly.
They will see how you act. They will see how you treat people. They will see how you treat your wife.
Yep.
It's so important for me to show him what a loving husband is, because I didn't have that.
Yeah.
Right. I didn't have a father who was around, who treated my mother with respect.
Yeah.
Right. They just argued all the time. So, all of these things I just thought about, and I thought about where the gaps were, and I came up with a plan. And it's been easier to follow this stuff now through all the chaos of having a 9-month-old, because the groundwork was laid before. And I think it's, that old meme where it's like the guy has a bunch of arrows in his back protecting his kid, and the kid doesn't see the arrows. I plan to show him the arrows.
Yeah.
Right? Because I want him to see me being vulnerable and experience when things aren't going our way. Okay, son, as a family, this is what's happening. This is what me and your mother have decided to do about it. Do you have any thought? I might not implement what they say, but I want him to feel like he's a part of the family and what's going on, right? Because my parents sheltered us from everything. And so I don't think that's the best thing to do, really. I think the best thing is to show them the range of emotions, talk to them about what's going on, talk to them about, hey, here's what I'm struggling with. So he knows that, hey, if he's ever struggling with something, I'm open.
Yeah.
Come talk to me.
You can come to me and talk to me, right? Mm-hmm. So that's a really good point. And that even applies not just in family life, but even in medicine, right? We see a lot of things in medicine that is stigmatized. I mean, weight loss is a great example, right? We've been talking about it forever, and we see this in modern day media all over the place. You're on a GLP-1, and when it first came out for weight loss, it was so stigmatized. Oh my God, you're stealing meds from diabetics, right? Oh, I can't believe you're on a GLP-1 for weight loss. Why don't you just work out? Why don't you just eat healthy, right? So there's all this stigma that gets created, And it's very similar even in a family situation like that. So just transitioning into medicine, right? What are you seeing in medicine that's so stigmatized now, and what communication we can break down? And the stigma is so uncalled for, if you want to call it. Like, it's just like coming out of nowhere, and people are stigmatizing because they just don't understand it.
Yeah, I think obesity is probably the biggest thing, because a lot of people are one cause, one effect. That's the way they think, because it's intellectually easy, right? So if someone's obese, it's because they're not trying hard. If someone's obese, it's because, it's their fault, right? Now, I'm not saying that personal responsibility isn't a thing. Of course it's a thing. At the end of the day, we're choosing our actions every single day. Now, certain people are going to be in certain situations where actions are easier for them than others, right? But we also have to look at systematically what's happened, right? We're in a very hypercaloric world, right? A lot of people don't have access to fresh fruits and vegetables, or even a supermarket that sells those types of things, right? Then we're in a hustle economy. I think one of the best things people can do is live outside of the US and see, like, oh, I don't need to work 70 hours a week to be happy, right? But here, that's just what is expected of us. We're in very high stress environments. We glorify not getting sleep, right? I'm team no sleep, team no hustle. Oh, I had 5 energy drinks today, I feel great, So our environment dictates a lot of what happens, right? And so until we systematically work through environmental constraints, then we can't just willpower our way through everything, right? Some people that's going to work for. Other people, it's not. And I'm just glad that we have safe and effective tools to help people on their journeys wherever they're at. So I will never force someone to be like, oh, you need to lose weight to solve all your problems, right? But the way I approach it is like, hey, if you are wanting to lose some weight and see if it helps you with how you're feeling, maybe your diabetes, hypertension, your arthritis, whatever, here are some tools that allow you to do so. So I'm going to talk to them about diet. I'm going to talk to them about exercise. I'm going to talk to them about sleep. I'm going to talk to them about GLPs. And I'm going to let them choose whatever avenue that they think is best for them.
Yeah, because they have to have buy-in, right? They have to believe that what they're starting is initiated by them. And there's this whole thing about, there's almost this whole cultural movement now of distrust in physicians and what physicians tell you to do, or what healthcare practitioners tell you to do. A lot of it's unfortunately brought on by social media and a lot of misinformation out there, which is what our mission is to demystify those myths that are just circulating around and just misleading people. So in that scenario with dads, just going back to dads, right? Like obesity is obviously a problem, GLP-1s stigmatized. What are some of the things that are stigmatized when it comes to new dads? Like, what can they do in this high stress environment of lack of sleep, their cortisol's through the roof, testosterone's declined 10 to 15% post having a baby. Now you've also got postpartum issues if you have that with your wife to deal with. That's an emotional constraint. A lot of guys don't talk about that. So like you said, it's all about communication and talking about your issues and being more vulnerable. And as a society, I think we're moving in that direction. It's going to be a bit more, it's going to be a little longer before it's more commonly accepted. But what can a guy who just had a kid do to cope with these things?
Yeah, absolutely. So the first thing is realizing that it's okay to ask for help, right? It's okay to seek out resources. And then there are so many tools that we have in our toolbox, right? If you need to lose some weight, we have tools for that.
Yeah.
If your testosterone has dropped and you feel like crud, which I see a lot of guys that happens, and not all of them are overweight or obese. Some of them are, they're eating well, they're exercising, they're doing everything right. We've looked at all the reversible causes, and their testosterone's still low.
Yeah.
There's therapies that we have for that, and it doesn't have to be testosterone replacement therapy. There are other things that we can use to not naturally, but to increase testosterone levels that the body making its own testosterone, right?
Yeah. So increasing your endogenous production, right? Without getting external testosterone in, which is what's commonly known as testosterone replacement therapy, not going to testosterone directly because it has its negative effects, but what are those things you can use, or those tools, as you call them, medications-wise, that are you commonly use in your practice, or you've seen used in Nimbus that help these guys?
Two of the big ones that I like to use are clomiphene or Clomid and HCG, human chorionic gonadotropin. I tend to prefer HCG over clomiphene because it's so. In pharmacology, you have to look at how close are you to the root cause of the problem, right? So in general, as I've gotten older in my approach to pharmacology, I like things that are furthest are not that far from the step that I want them to do, right? It's like kind of what are those Rube Goldberg machines or whatever they're called, where like you drop the thing in and it goes through all these different wonky pathways to get to the destination. Well, why can't I just go directly
direct pathway,
to the direct pathway? So agents that are direct pathway, I'm very interested in that because there's less variability, in my opinion, between like genetics or environment or anything like that, right? So I've used both. It just depends on, there's slight differences in adverse effect profiles. One's oral, one's injectable, right? It's subcutaneous, which is easier for people to do than I am. And we could talk about that. I prefer subcutaneous injection to IM injections.
Most of our patients do too, right? Most guys do. Nobody wants to give them a shot in the buttocks or in your thigh. Intramuscular shots are like frowned up. I mean, guys just hate doing it. And subcutaneous shots are so much easier to do. And now we have research showing that testosterone can be even used subcutaneously, which we've adopted in our protocols here at Nimbus. But going back to HCG and clomiphene, right? Because those are the two big tools we have in our toolbox to help guys who still want to have kids. Right. That's the big differentiator there is when you still want to have kids and spermatogenesis or having the ability to actually produce viable sperm longer because you want to have kids, then those are the two tools you would typically use. What percentage of your patients do come to you asking for these kind of things typically? Or is it because they don't know any better, right? Because being new dads, right, we can empathize with these guys, right? Like, everything's off. Like, anybody who tells you that they had a kid and things are all just fine and dandy is lying to you, right? Like, you have to deal with your wife's hormones. Your kid is not sleeping through the night. Your sleep is disrupted now. Cortisol's off. You still have work stuff to deal with. You still have to be a man of the house, provide. So things are off. So what percentage of guys typically come to you even thinking the hormonal shifts is a problem?
A lot more now. I think there's a lot more awareness of low T and the effects of testosterone. We can back up and say, well, what is testosterone used for? It's a hormone, a lot, right? Our muscle mass, where we distribute body fat. There are metabolic effects of testosterone. So blood sugars, blood lipids.
Neurotransmitters, right? I think the biggest misconception that kind of irks me all the time when people, I guess that's how social media has just stamped it, right? You hear testosterone and the first image that goes through most people's heads is Arnold Schwarzenegger or Phil Heath and just building muscle, right? That's what everybody thinks of. But it's so much more than that. It is the fundamental chemical messenger in your body that's got all these pathways it works on. And when it goes down, you're not just losing muscle mass, like it affects your neurotransmitters, your dopamine, your norepinephrine, all these things that make you feel happy and good about yourself and does the positive reinforcement pathways, right? So it's good for guys to know that it's not just testosterone. Testosterone is just not linked to muscle mass, right? There's got all these other effects that helps you live a better life.
Right. Yeah, because the mood is probably the number one reason that I try it in people, right? And I'm not as dogmatic adhering to the guidelines on it as I used to be. It used to be, oh, you need 2 levels less than 300, otherwise I'm not going to prescribe it.
And we can do a whole podcast on that, on where guideline-based care has gone. And it's good to see how regulatory bodies are peeling off the black box warnings. And even for testosterone, forever it had the black box warning for cardiovascular risk, which they've repealed, right? So like, I think I think it's probably the entrepreneurial side, ventured out of the box of guideline-based care to see anecdotal evidence in patients we treated to see, oh, this stuff actually works. I'm going to try it on this guy. Oh, this worked for him. So you see so many of those cases, right? You start seeing, okay, maybe the guidelines aren't the best way to go. Is that how you feel?
Yeah, for an individual, they're not. For a population, sure, right? Because that's what they're designed for. But I've seen it both ways. I've had people come in, their testosterone's like 350, and they feel like crud. And I'm not trying to jack their testosterone up to like 17, 1800, right? There's no reason for that. But let's see if I can get you to 600, 700, right? And see how you feel, right? I can do that relatively easy, low doses, very safe, right? And if you feel better, great, right? Then we know that there may be something here with the testosterone that was causing that issue. If you don't feel any different, okay, let's investigate other reasons for this to be happening. Because I think it's an interesting theory that I've had. I've seen people with testosterone like a 150 and they have no symptoms. They're jacked. They feel great. And I think
they're jacked.
Yeah. I think it might be like some people have a hyper-functioning testosterone receptor.
Yeah.
Right. And so that low testosterone is protective. Right. And so what happens if I give that patient testosterone without any reason to?
Probably the opposite effect. Right. So just for our audience, right. And that's one of the core missions of this podcast is to be easy to understand. When you say hyper functioning testosterone receptors, what does that mean? Yeah.
So we know that there are certain things that are conserved, right? Testosterone needs to bind to something.
The lock and key.
Right, the lock and key, right? But we don't all have the same lock. There are different locks, right? So some people's locks may function average, right? Some people's locks may function worse. Like it's a lot harder for the key to open the lock, even though it's the right key. Some people's, the locks will open to just about anything.
Yeah.
Right. And so these people, like they get a profound downstream, effect. So what happens when testosterone binds to that receptor? It's just much more effective. And so in these people, the body will try to regulate that to make sure that nothing bad happens. So it'll make less testosterone because it doesn't need to make as much because it's getting the same effect with less. So these are the things that I have to think about. And, I'm a very symptoms focused physician, right? If I'm just treating a level, anybody can do that.
Exactly.
Right.
And that's why we always say, don't treat the labs, treat the patient, right?
Exactly.
If you just go off the numbers off of a sheet, like you said, there's so much variability in that, but the patient knows or the client knows that something's off. So that's where I think good medicine is practiced typically if somebody's willing to listen to them. I think that's also a big problem in our healthcare system today where physicians don't have enough time to spend with the patient and have that conversation to actually get to the bottom of this is how they're feeling.
Right.
Right.
And when we designed a better, we collect a lot of data beforehand. So before I even meet with people, I'm getting a lot of information about them. And then I go through that information, I go through the lab work, we do a very comprehensive initial lab assessment. So, and then I can start piecing through things together. And then we talked about the first question I ask them, even though I have that data, I want to hear in their own words, what are your goals?
Yep.
Right? Because that's going to tell me the frame which I apply everything else through.
Yep.
Right? Because it's no good to me if I recommend something to somebody and it's not in line with their goals.
Yeah.
What's the point?
Yeah. Because everybody has different goals, right? Some people might want recovery from a previous injury. Some people might want to live longer. Some people might want to just get jacked. But at the end of the day, it's what they want, right? It's not what we think they want.
Right. That's that old paternalistic model of medicine. The physician knows best, do what I say, right? And that's not the kind of physician I am. I want to help people achieve their goals because that's going to improve their quality of life. And, when we're in medical school, we're taught about hard outcomes. It's all hard outcomes. I need A1C lowering. I need LDL-C lowering. I need hard outcomes. And then now that I'm in my 40s, it's like patients just want to feel better. Yeah. That's the most important thing to them. So how do I take, these hard outcomes that I know will lower their risk or improve their longevity or whatever, and balance that with how do I get them to feel better?
Yeah.
And when you pair the two together, that's where medicine really shines. What's been really interesting about this journey is that oftentimes whenever I'm trying something new, I'll use myself as a test case.
Oh, yeah.
Right. And so I've had some injuries, right? I've got thoracic scoliosis. I've got an L4 that's congenitally tight, right? So I've had sciatica since I was 12 years old, 13 years old. My dad has it. His dad had it, right?
Genetic,
right?
Yeah.
And I herniated a couple discs a few years ago, and I was a power lifter. You know, I had 600-pound max deadlift at 200 pounds.
Yeah.
Right. So after that, I had to stop. And I remember when I tried BPC, for like 2 months, I didn't feel any different. Right. And then I was like, one day I was like, you know what? I'm going to try a deadlift again. And I went from not deadlifting since 2018 to within 3 weeks, I was deadlifting 400 pounds again.
No, wow. Yeah. And you think BPC had a lot to do with that healing process?
A huge effect, because I always try to run things like a quasi randomized controlled trial, right?
Yeah.
So whenever I'm changing something in my routine, I change one thing at a time.
Yeah.
Right. And yes, it's anecdote, right? But at the same time, I try to make it as scientific as I possibly can. And I remember I posted this on Instagram that I was deadlifting again, and a physician from South America that I've had contact with, all he said back was BPC-157 ?
That's funny. That's funny because these peptides are widely used internationally, right? And they're actually not like easy to obtain, medically supervised. For some, I mean, hopefully in our country that'll be the case too once the FDA figures out how to manage these things. So when a pharmaceutical company discovers a new chemical, right, or a peptide, whatever you want to call it, it has to be protected, right? It has to be synthesized in their lab or different enough to where they can apply for a patent. When they apply for a patent, they have it for about 21 years, if I remember correctly. And then it's a race. Then it's a race to get FDA approval and go through all 4 phases within that 21 years. The faster they do it, the more time they have on their patent to make money, right? Where a lot of these therapies don't get researched or don't get adopted by big pharma is because, one, they're already available, right? BPC is a natural peptide produced in your gastric organs, right? So it's not something that you can go patent. So why do a study on something that's not patentable? That is like the biggest reason why you don't see adoption for these, or major adoption for some of these peptides on a pharma level or guideline-based care level. But it doesn't mean they don't work. And we're seeing anecdotal evidence, like you said, on you use it and you were back lifting with 400 pounds in 3 months?
Yeah. Yeah. And so like recovery from injury is not a disease.
Yeah.
From a traditional medical perspective, right? So if I'm sitting in a boardroom, how am I going to sell that to the guys in the boardroom? Well, we're going to treat people occasionally when they get hurt.
Yeah, I mean,
that's get out.
Yeah. Right? Where's your recovery and revenue model, right?
Right.
Yeah.
Right.
Do you want to kind of go over like how those protocols are structured and why there's a cycling effect and using something for a month to 2 months at a time, and where the benefits and what the risks and rewards are?
Sure. So let's look at like growth agents, BPC-157, TB-500, and I'll put sermorelin in that category, but then I'll talk about it a little differently. You have to be really careful with how you regulate growth. Mm-hmm. Unrestrained growth all the time is not a good thing. And people used to look at, oh, well, all these bodybuilders die early, working out must be bad for you. It's like, no, it's the fact that they're on anabolics, growth promoting agents all the time.
All the time.
All the time. And that's why, a recent study showed they die at 5 times the rate of amateur bodybuilders.
Yeah.
Because they're on all these growth agents and they all die from heart failure or arrhythmias.
And it's typically, in that study that we looked at, right, that you sent, it's typically cardiomegaly, right? So it's basically when they do autopsies on these individuals who passed away early, who were in great shape, they see that the thickness of the heart, cardiomegaly, is so large. Right? That's what they were saying?
Yep. Yeah, so there's something called the Frank Starling law if you want to nerd out on something.
Yeah.
So
basically, that's what this is about. Yeah.
As the heart muscle gets thicker, right? So when you exercise, your heart muscle will hypertrophy. It'll get larger, right? And it does so to pump out more volume. That's called stroke volume. How much volume is the left ventricle pumping out, right? And when you're exercising, that makes sense. You need more blood delivered to your muscles to continue to do progressive overload, to get stronger or faster or whatever.
And the more often you do it, the stronger the heart gets, right? That's the whole concept.
That's the whole concept. And that's beneficial to a certain point. Then when the heart gets too large, that pumping, that rhythmic pumping of the heart becomes disordered. And what that happens is it leads to heart failure. So now the muscle's too large to pump in an organized fashion. So now the cardiac output, what we call how much the heart's putting out, decreases. And so that's why these people tend to die from sudden cardiac death because of heart failure. It's also why you get more arrhythmias, because that muscle pumping is disordered. So now it's more prone to get out of the normal rhythm and the normal beats. So that's the problem with disordered growth just for the sake of grow.
Unchecked, not medically supervised care can lead to that.
You know, we've seen this in patients. We've treated a lot of patients who have had surgery and they want to recover from their surgery. And we've used BPC and we've used TB-500. And I will only use it for about 3 months in that situation, because anything that works on angiogenesis, which is generating new blood vessels, you have to be very careful, because that's a primary mechanism for cancer cells to spread, right? And we actually have drugs that target something called VEGF, which is a primary molecule for generating new blood vessels. That's how they work. They prevent these cancer cells from developing this disordered network of blood vessels to feed their growth, right? There's also another one that no one's talking about, and that's macular degeneration. A specific type called wet macular degeneration is involved with abnormal blood vessel growth in the eyes, angiogenesis. Diabetic retinopathy, so how diabetes affects the eyes, it generates abnormal blood vessels. And so we use drugs to target that in those conditions. So that's what happens when you have abnormal growth for too long.
Yeah. And this is probably a really good segue into something I did want to talk about. Peptides, which is another tool that we have in a tool chest to use to get these patients feeling better. So, as you know, there's this whole gray market. I mean, peptides are the hottest thing on the market now. You can't open up Instagram without seeing somebody trying to sell you peptides, right? It's crazy. Even though they have no clinical background or any experience in this, which is just drives me bonkers. But there is this gray market of research use only peptides that's popped up that's not meant for human use, right? It literally says research use only on the vial, on the label, and people are going and buying these online. And this ties back to what you said about patients just want to feel better. People just want to feel good, right? So they're having to go outside of normal healthcare practices, outside of the normal healthcare system, go online and buy these shady peptides from the shady website with no medical supervision, right? Because somebody told them they were going to feel better if they take this thing, right? So what's your take on that? Like, is that accurate? Like, overall, on a high level, what's your take on that?
Yeah. So I remember when peptides first started to get more mainstream, you and I had conversations about it, and we were both like super skeptical, right? Which I think is healthy. I think as a physician and a pharmacist, people are putting lives in your hands. You have to have a healthy bit of skepticism, but you have to be open too. And that's a fine balance.
It's a fine line.
It's hard to learn how to walk that balance. And so at first I was like, hard no. And then I took a step back. And I said, well, people are going to use these things. I need to educate myself about them. So I started diving into the research, looking at things. You know, a lot of this is from mouse models or very small studies in humans, if there are studies in humans. Some agents do, some agents don't. And then I started building out a framework of how do we use these things safely, knowing my understanding of pharmacology, right? Because you can give me how something works and I can figure it out because of our backgrounds in pharmacology. We know that. We understand how drugs work inside the body. And so I had to really dive deep into our background in pharmacology to figure out guardrails for these things and who's an appropriate candidate and what's an appropriate candidate and how long to use it and when to use it and all of that. And I think the space right now is everybody's just like, oh, take these like they're water.
Oh, yeah. Take this. You're going to feel great, right? That's the sell from, I mean, I see like all these random people online just telling people to take things like BPC-157. You're going to feel great. I mean, do you even know what the drug does? Like, do you know what this peptide does? Like, and we could dive into those specific peptides here in a bit, but like the amount of misinformation that's out there about these peptides is just unfathomable. And the fact that it's allowed to even happen is crazy with no medical supervision, but it also shows you that there is a market for this from a business side, right? And a lot of it has to do with the fact that the healthcare system has let these people down.
Correct.
And they are seeking help outside of normal means to get these things, either because the physicians don't know anything about it, they don't want to learn about it, because they're still following guideline-based care. Very few people venture out, and this is what they're being told.
Yeah, absolutely. So it goes back to that approach that we talked about earlier. It's being very patient-centric, and we're not just throwing the kitchen sink at people. And I don't use more than 2 agents at a time.
Yeah, because you never know what's working.
You never know what's working. You never know how these things are going to interact, right? I'm a huge believer in informed consent. When I'm talking to people about these peptides, I'm telling them, here's what we know, here's what we don't know.
Yes.
We don't have any human studies on this. We have great mouse studies showing efficacy. We're not mice, but that's where we have. And I think based upon the pharmacology of this agent, this is how I can use this agent to help you, right? And the difference is these aren't research grade peptides.
They're pharmaceutical grade.
They're pharmaceutical grade. There's a big difference in, CGMP, current good manufacturing practices, which is a set of principles you have to make when you're making things for human consumption. Research, you don't have to follow that, right?
So and let's dive into that a little bit more, right? For the audience that doesn't know, what is the difference between research use peptides that say not for human use and compounded prescriptions from a 503A compounding pharmacy or a 503B compounding pharmacy, right? So when you're doing research use only peptides, you have no idea where they're coming from. You do not know if there's contaminants in it. It is not intended to be used for medical use, right? And that's how they skirt the rules around the FDA. The FDA only imposes their will on intended use. So when you literally say it's not for human use, then they're kind of skirting the line on having to follow any of these regulatory practices for delivering good quality products to people. But people still use it. And it's a lot of people using it, right? We have data to show how many people visit these sites based off of all the tech that exists today, and it's wild. So like the difference between research use and then we have compounded prescriptions, right? The compounded prescriptions, one, have to be written by a physician. There's medical supervision there. Their pharmacies have to follow USP guidelines. And at the end of the day, if you're following USP guidelines, the compounded prescription is tested for potency, purity, endotoxin testing to make sure it's not going to harm somebody. And what goes out of the door to the patient is actually what's in the vial, right? That is the biggest thing that I think most people are missing, is that this stuff is research use only peptides are not intended for human use. You have no idea if you're getting chalk powder in a vial, right? And they have to reconstitute it. Just the fact that they have to reconstitute this without any instructions, because they can't even give them instructions technically, because once the research use manufacturer tells a patient or a client, whoever's buying their stuff, this is how you should reconstitute it, they're breaking the law. Because why would you have to tell them how to reconstitute it if you're doing research? Right. So some of these people don't even know what they're doing when it comes to reconstituting. Are they taking tap water and putting it in here? Like, who's guiding people on this journey? And it's so bad. And I wish there was somebody looking at the amount of sepsis that's happening or the infections that are happening when people are using these things, or like just high doses leading to issues.
Yeah. And like, even if the worst case scenario is you get contaminated product, sepsis, that kind of thing, even if it's not that, low levels of exposure to endotoxins, like these are bacterial byproducts. Lipopolysaccharides is a big one, LPS, that there's standards for human consumption that have to be followed, that doesn't have to be followed for research purposes. Best case scenario is that you're inducing small level chronic inflammation every time you inject.
Yeah.
Right. That's best case scenario for this. When we do studies on people and we want to check inflammation, we inject them with LPS.
Yeah. The biggest difference between if there is LPS, right, is because sometimes people ask me, so how do compounded prescriptions prevent that from happening? Like, how do you guys ensure, if as a compounding pharmacy, that you don't have those endotoxins in your final product? One, it's following the process and making sure the mixing and all that's happening in an ISO class hood, right? That's why you see the hoods in a compounding pharmacy. So following proper gowning procedures, not introducing bacteria into the situation. So there's a lot of rules that need to be followed, even when you're handling these chemicals. And say worst case scenario, there is something that gets in, right? Your end product is sterilized by a couple of different forms, depending on what the product is. One could be autoclaving. Like you literally heat it up to a certain temperature where all bacteria and viruses die, as long as it doesn't affect the byproduct, right? The other one is it can go through a filtration mechanism. So when you're filtering these things out with sieves that are so small and capture viruses and bacteria, you're getting rid of all the stuff. So your final product goes through all these sterilization techniques that it should be very pure. And on top of that, that product has to go out for testing. So you're testing for potency, you're testing for purity, you're testing for endotoxin, and making sure that there's no harm that can be done by getting this thing out the door, right? So that's the biggest difference between research use only peptides and compounded products, if anybody's wondering. All right, Rich, I've got some lightning round questions for you.
Right.
So keep them short, 15 to 30 seconds. All right. TRT, overprescribed or underprescribed?
Both.
Both?
Yeah.
Okay.
It's overprescribed for people who don't need it. It's underprescribed for people who need it.
Ah, good answer. Okay. Should every man get hormones checked at 30?
I would say no. I hate to say everybody should do something, but it's a good idea to get them checked if you're having issues that we talked about earlier.
Got it. Best supplement actually worth the money?
Creatine.
Creatine. Why?
Everybody should be training with some frequency of intensity. It's the best supplement for that.
Got it. Worst health trend you want to die?
Carnivore diet.
Why?
Fruits and vegetables are almost universally, I've never seen a study that shows that fruits and vegetables actually hurt people in any long-term outcome that's actually worth it.
One piece of health advice for new dads?
Find time to still work on yourself, whether that's 10 minutes a day, 20 minutes a day. Figure out time to still do the stuff that matters, like exercise and stress management and all that stuff.
That's great advice, Rich. That was a blast, man. Thank you so much for joining us today. It's an honor and a privilege to keep working with you, and I'm glad you were our first guest on the Honest Dose podcast. So our audience probably wants to know how to find you, and I know you have a book coming out soon. So tell us what the book's about and when it's coming out and how people can find you.
Sure. It's called White Coat, Heavy Soul. It's a memoir of my journey to becoming the physician that we talked about today and all the ups and downs and things I've learned along the way. On social media, I'm very active on LinkedIn, Dr. Richard Harris, and then on Instagram at Dr. Harris MD. Those are my two preferred social medias.
Awesome. Awesome, man. Well, I'm looking forward to reading that book. I know you've been putting a lot of work into that, and now the audience knows how to get a hold of you. So obviously, we'll keep working together, but it was a pleasure, man. Thank you for joining us today.
Thanks for having me.